Hi guys, welcome so much to Dr. Krishnan Lecture. This is a channel dedicated to make learning easy for all the medicos and create an amazing community of super awesome people like you. Regards, CEO and founder of Dr. Krishnan Lecture, Dr. Ramesh Krishnan.
In this lecture video, I will discuss about approach to muscular dystrophy. The content of my lecture include negative and positive symptoms and signs of muscular dystrophy, durations of evolutions of muscular dystrophy, distribution of weakness of muscular dystrophy, precipitating factors of muscular dystrophy, associated symptoms and signs of muscular dystrophy, diagnosis of muscular dystrophy based on pattern of inheritance, investigations in the patients with muscular dystrophy. Now, the symptoms associated with muscular dystrophy or the myopathies include the negative symptoms in the form of exercise intolerance, fatigue, muscular atrophy and weakness. Whereas the positive symptomatology include cramps, contractures, muscle hypertrophy, myalgia and myoglobinuria. Myopathies associated with muscle contractures include body disease, glycolytic or glycosinolytic enzyme defects, myophosphorylase deficiency, also called as McArdle's disease, phosphofructokinase deficiency, phosphoglycerate kinase deficiency, phosphoglycerate mutase deficiency, lactate dehydrogenase deficiency, de-Brancher's enzyme deficiency and Ripple's muscle disease. Myopathies associated with muscle stiffness include hypothyroid myopathy, myotonic congenita, paramyotonia congenita, myotonic dystrophy type 1, myotonic dystrophy type 2, hyperkalemic periodic paralysis. Myopathy associated with myoglobinuria, the causes include prolonged or intense exercise, drugs and toxins, metabolic myopathies in the form of myophosphorylase deficiency, lipid disorders with the cause include carnitine palmitoyl transferase deficiency, malignant hyperthermia, central core myopathy, Duchenne muscular dystrophy, limb-girdle muscular dystrophy with the type 2C to 2F, also called sarcoglycanopathies and dystrophinopathies. Myopathies associated with myalgia, the causes include drugs and toxins-induced myopathies with the drugs statins, eosinophilic myalgia syndrome, hypothyroid myopathies, inflammatory myopathies with the dermatomyositis and polymyositis, myotonic disorders, mitochondrial myopathies, tubular aggregates myopathies and infectious myositis, especially viral. Then, what is the temporal evolutions of the myopathies in the headings of onset, duration and evolutions of patient symptoms? If the patient presents with episodic periods of weakness with normal strength, the causes include periodic paralysis metabolic myopathies with the cause include glycolytic pathway disorders. If the patient has constant weakness, the acute and subacute progressions include inflammatory myopathies with the cause include dermatomyositis and polymyositis. Chronic and slow progressions over years, most of the muscular dystrophies and inclusion body myositis. If the patient has non-progressive weakness with little change over decades, it can be mostly due to congenital myopathies. Then the diagnosis of myopathies based on age of onset. If the myopathies are present at birth, the causes include central core disease, central nuclear myopathies in the form of myotubular myopathies, congenital muscular dystrophies, glycogen storage disease in the form of acid maltase and phosphorylase deficiency, lipid storage disorders like carnitine deficiency and Lemnin-Rhodes myopathy. If the myopathies are present in the childhood, the cause include congenital myopathies with the Lemnin myopathies, endocrine or metabolic myopathies, glycogen storage disorders like acid maltase deficiency, inflammatory myopathies with dermatomyositis, and lipid storage disorders like carnitine deficiency, mitochondrial myopathies, and muscular dystrophy with the causes include congenital, Duchenne, Vickers, and Emery-Dreifuss myopathies. If the myopathies are present in the adulthood, the causes include endocrine myopathies with thyroid, parathyroid, and adrenals, inflammatory myopathies with polymyositis, dermatomyositis, and inclusion body myositis. Then metabolic myopathies with acid maltase deficiency, lipid storage disorders, deep branches deficiency. Muscular dystrophy with the causes include limb girdles, fascioscapulohumeral, Baker's, Emery-Dreifuss, and myotonic dystrophy. The toxic myopathies with the alcohols and corticosteroids. These myopathies are present in the adulthood. Then the distribution of weakness. If the patient has proximal weakness in the form of limb and girdle weakness, the causes include dystrophinopathies, limb girdle, myofibrillary myopathies, and myotonic dystrophy type 2, as well as central core, multi-mini core, and centronuclears and Lemnin-Rhodes myopathies. Metabolic myopathies in the form of glycogen and lipid storage disorders, mitochondrial myopathies, inflammatory myopathies in the form of dermatomyositis, polymyositis, and anti-synthetase syndrome, toxic myopathies, endocrine myopathies, and neuromuscular junction disorders also present with proximal muscles weakness. These neuromuscular junction disorders include myasthenia gravis, Lambert-Eaton myasthenic syndromes, congenital myasthenia, and botulism. If the patient has distal weakness, the causes include myofibrillary myopathies, congenital myopathies in the form of late onset centronuclears, and Lemnin-Rhodes myopathies. Metabolic causes of glycogen storage disorders like branches and debranches deficiency present with distal muscles weakness of the limbs. Lipid storage disorders with neutral lipid storage myopathies, multi-acylase dehydrogenase deficiency. In these cases, patient present with distal muscles weakness of the limbs. If the patient present with proximal arm and distal leg weakness, the causes include fasciculoscapulohumeral muscular dystrophy, scapuloperoneal myopathies and neuropathies, with their causes include myofibillary myopathies, Emery-Dreifuss muscular dystrophy and Wethlem myopathies. If the patient present with distal arm and proximal leg weakness, the causes include inclusion body myositis and myotonic dystrophy. Axial muscle weakness. The causes include cervicobranchial myositis with the sporadic inclusion body myositis and hereditary inclusion body myositis. Myotonic dystrophy type 2 with isolated neck extensors myopathies and wind spine syndrome. Fascioscapulohumeral dystrophy, late onset central course like ryanodine receptors 1 mutations present with axial muscles weakness of the body. Sporadic late onset lamellin rods with or without monoclonal gammopathies. Metabolic or late onset Pompe's, McArdle's and lipid storage as well as mitochondrial myopathies. Hyperparathyroidism, osteomalacia, vitamin D deficiency and myasthenia gravis. These patients present with axial muscles weakness. If the patient present with eye muscles weakness with ptosis and ophthalmoparalysis. Ptosis without ophthalmoparalysis, the causes include myotonic dystrophy, congenital myopathies as well as neuromuscular junctions disorders. Ptosis with ophthalmoparalysis, the causes include oculopharyngeal dystrophy, mitochondrial myopathies and hereditary inclusion body myositis type 3. If the patient present with episodic weakness or myoglobinuria, if it is related to exercise, the myoglobinuria presented after the patients perform exercise, the causes include glycogenolysis defects with McArdle's disease, lipid storage disorders like carnitine palmitoyl transferase deficiency, mitochondrial myopathies in the form of cytochrome V deficiency. If it is not related to exercise, the causes include ryanodine receptors 1 mutations with the malignant hyperthermia, drugs and toxins like statins, prolonged or intense eccentric exercise, inflammatory myopathies in the form of polymyositis and dermatomyositis. If it is unrelated to exercise, the causes include periodic paralysis like hereditary hyper and hypokalemic and thyrotoxicosis, as well as renal tubular acidosis. If the patient presents with vulvar or tongue or pharyngeal muscle weakness, the causes include myasthenia gravis and Lambert-Eaton myasthenic syndrome. If the patient presents with muscle stiffness or decreased ability to relax, it can be because of myotonic dystrophy type 1 and 2, myotonia congenita, paramyotonia congenita, hyperkalemic periodic paralysis with myotonia, potassium aggravated myotonia, Schwarz-Jampel syndrome, Ripple's muscles disease, and acquired neuromyotonia like Isaac syndrome, stiff person syndromes and Wardy disease. In these cases, myopathy is associated with the stiffness or decreased ability to